you come to maybe something like stomach cancer, it will present like something like gastritis, like H. pylori. So you might be treated for things like the H. pylori or the gastritis while it is cancer. So basically for you to prevent cancer is to eat healthy, and eating healthy, I mean eating a lot of fruits and vegetables, eating a whole meal when it comes to carbohydrates.
Yes.
Because nowadays we are eating a lot of refined carbohydrates. If you go to the shelves in a supermarket,
Yes.
the unga that is so refined
Yes.
is the one that will get a lot of customers. Most of the treatment, the chemotherapy and the radiotherapy, target the rapidly dividing cells. So if you get the chemotherapy or if you get the radiotherapy, the cells that will be destroyed are the cells that are in their cycle. We call the cell cycle.
Yeah.
Those are that are actively dividing at that time. So sometimes you will find that some of the normal cells, especially the lining of we call the gastrointestinal system, the hair is dividing, sometimes the skin is dividing. So because of that, now as they destroy the cancer cells, they will destroy the normal cells.
Hello viewers. Cancer is the third leading cause of death in Kenya, according to a report by the Kenya Network of Cancer Organization, KENCO. About 29,000 Kenyans lose their lives to cancer every year. Globally, an estimated 20 million new cancer cases and 9.7 million deaths were recorded in 2022. Projections indicate that cancer-related deaths could rise sharply, reaching 18.6 million annually by 2050. In our first episode of Health is Wealth, we sit down with an oncologist to discuss this devastating disease, its impact, prevention, and the hope that lies ahead. This show is brought to you by Kibali Pictures, and I am your host, Blessed Sam. Hello.
Hi.
I'm so grateful that you found time to come to the show to speak to us about cancer. Cancer imesumbua watu wengi. It has really taken a lot of people, and I hope that you will talk to us about it.
Yeah, thank you very much for having me. I'm so glad to be here.
Yes.
And it's true, cancer, this is a timely discussion because cancer has become very common. Not like previously when you used to hear about cancer from afar.
Yeah.
But now you're hearing your friend, your neighbor, your cousin, your mother. Yeah, it's a real problem and we need to get to know about.
I'd want to ask you, what is cancer?
Okay, cancer is not just one disease,
Yes.
but many diseases. We call it a disease of the cell.
Yeah.
A cell is the tiniest component of a human body. A human body is made up of millions of cells or billions of cells.
Yeah.
So normally the cells are able to control how they multiply.
Yes.
And these basically happen by three things, or we call them genes that control the multiplication. There's a set of genes that allows the cells to divide or to multiply. Yes. Or demand or give a signal for multiplication to take place. Then there are those genes that tell the body to stop the multiplication. And then there are those genes that control the damage of the DNA. During cell multiplication and there is some damage in the DNA, there are those cells that control or repairs the DNA. So if any set of the three genes has an abnormality, and now cells divide uncontrollably, that is what we call cancer. So it can be the cells of the breast, now we call it breast cancer. If it is the cells of the prostate, we call it prostate cancer, and so on and so forth.
Yes. What is causing cancer?
We do not know exactly.
Yes.
We cannot pinpoint one thing that is causing cancer. But just as we have said, what will happen is that as the genes get mutated, it takes a long process. Okay. And there are several factors that can predispose. We say it's predisposition.
Yes.
A predisposition of these genetic abnormalities.
Yes.
Then now, with these genetic abnormalities, you can now get cancer. But before I start on them, it does not mean that if you have any of the predisposition, it does not mean that you will get cancer. Yeah. What it means is that your chances of getting cancer is much higher than somebody who does not have a predisposition.
Yeah.
And if you do not have a predisposition, does not mean you will not get the disease. It only means that your chances of getting the disease is much lower. Okay. Different cancers have different predisposition, but doing it in general, there are those factors that we say you cannot control and control. There are things that are beyond our control.
Yes.
That includes the gender. There are some cancers that are more common in women. There are some cancers that are more common in men. But generally, because breast cancer and cervical cancer are among the leading causes of cancer, so being a woman you have a higher chance of getting cancer. So being a woman or being a man, that is something that you cannot control.
Yes.
Again, the other thing is age. You cannot control your age. Yes. There are some cancers that are more common in children, and there are those cancers that are more common in the elderly or the older. Because the older you get, the more chances that you get predisposition factors.
Yes.
So the more you live in this earth, the higher the chances of you of getting cancer. Then there is genetic. There are those genes that we inherit from our parents that increases your chance of getting cancer. So that, again, it's something that you cannot control. But there are those factors that we are able to control, lifestyle factors. Also, before we move on, there's something else like hormonal, especially for things like breast cancer. Again, that you cannot, there are some aspect of hormonal that you cannot be able to control. Then on the factors or the predisposing factors that we are able to avoid is the lifestyle choices.
Yes.
The biggest culprit is tobacco. So tobacco in every form, whether it's the cigarette, whether it's the shisha, I know nowadays.
Yeah, there is shisha.
Yeah, the vapes.
Yeah.
Any forms of tobacco. And unfortunately, even second-hand tobacco. If I'm smoking and you're right next to me, you're inhaling.
Yes, I'm also smoking.
Yes. And again, our shoshos used to use the edible tobacco, the ones that they used to put under the tongue.
Yes.
So also that is a predisposing factor. The other thing is alcohol, especially if you take a lot. It's also a predisposing factor. Again, weight, obesity and overweight also increases chances of getting some cancers like breast cancer, colon cancer, even prostate cancer. Then we have things like diet, especially feeding on highly processed proteins and carbohydrates also increases the chance. And living sedentary lifestyle, unakaa tu, you're not exercising, that also increases the risk of cancer. That is just to mention a few.
Wow, there's so many. You know, a long time ago, I used to know, actually, people used to say that cancer is caused by, it's hereditary, that if you have a relative who had cancer, definitely, okay, there are high chances that you might get it. So, has it changed? Am I still the same?
Okay, it hasn't changed.
Yes.
But the hereditary aspect is very tiny compared to the erratic occurrence.
Okay.
So most people that we see, we are seeing a lot of patients with cancer, but they do not have any family history of cancer. So the genetic component is not, it's true, it's there is a genetic component, but it's not as much.
So we've talked about causes, and it's like there is no exact cause of cancer.
Yes.
So how can people protect themselves from getting it?
Okay, it's just avoiding the predisposing factors, and maybe knowing, like if in your family there is a lot of cancers, especially if those cancers happen at a younger age. So if the cancers are happening at a younger age, the chances of them being a genetic thing is high. So things like genetic testing will come in there. So basically, for you to prevent cancer is to eat healthy, and eating healthy, I mean eating a lot of fruits and vegetables, eating a whole meal when it comes to carbohydrates, because nowadays we are eating a lot of refined carbohydrates. If you go to the shelves in a supermarket, the unga that is so refined is the one that will get a lot of customers. If you go to the bread section, the whole grain bread rarely is not moving as fast as
the most refined.
The most refined. So a healthy diet. And when it comes to proteins, we also avoid the sausages. Instead of taking sausages, take the pork. Instead of taking the brown, take the beef. So you avoid the refined, a lot of refined foods. The other thing is stoppage of smoking at all. There's no level of tobacco smoking that is acceptable. And then when it comes to alcohol, you stop. If you cannot stop, at least minimize. And then you maintain a healthy body weight, and then being physically active, exercises, those kind of things will reduce the chances of getting cancer. And maybe when it comes to genetic, especially something like breast cancer, ovary cancer, and prostate cancer, there's something we call BRCA gene mutation. So we saw there's a musician, Angelina Jolie. Maybe you might have heard her story that she underwent a surgery to remove the ovaries. So in such kind of thing, you can do such kind of thing as a preventative measure. If you have that gene mutation, you can decide to remove your breast prophylactically, or just to prevent future occurrences of cancer, or remove the ovaries or something like that.
So there is also symptoms. A popular musician recently passed on, and people were wondering, what are the symptoms of this leukemia? What are the symptoms of prostate cancer?
Okay, so each cancer has its own symptoms depending on where it is affecting. But there are those general things. So what I tell patients, or what I tell people, is the best thing to do is knowing your own body. Because most of the time you will find that cancer symptoms are not specific for cancer. For example, maybe if you come to maybe something like stomach cancer, it will present like something like gastritis, like H. pylori. So you might be treated for things like the H. pylori or the gastritis while it is cancer. Things like cervical cancer might present like urinary tract infections, UTIs. Things like prostate cancer may present like benign prostatic hypertrophy.
What is that?
It is a disease of the prostate.
Oh, okay.
That it's generally the enlargement of the prostate.
Oh, okay.
Yeah, that is not cancer.
Yes.
So we call it benign prostatic hypertrophy that might present similar to prostate cancer.
Yeah.
So maybe in a general overview is a persistent cough. If you're coughing, you're going to the hospital, you're being treated, it is not resolving.
Yeah.
It's good to check.
When you're doing the screening, are you screened for all types of cancers?
Unfortunately, not all cancers can be screened.
Oh, okay.
Or we do not routinely screen most of the cancers, because sometimes screening, it has to be something that the country can afford.
Yes.
It has to be something that if it is found positive, there's something that you can do. Because something like prostate cancer, it's not hard to screen.
Yes.
It's easy to screen for prostate cancer, but some forms of prostate cancer are, for lack of a better word, they are harmless. That sometimes, in theory, we say you just watchful waiting, you just follow up the patient, you don't give any treatment.
Yes.
But as a doctor and as a patient, if you find that you have cancer, it's worrying, it's difficult to just sit and wait.
Yes.
Because you do not know the aggressiveness of this cancer. So some of those things are the ones that make screening a bit we are not able to screen a lot of cancers, but at least majority of cancers like breast cancer, cervical cancers, we are able to routinely screen for them.
Yeah.
Yeah. And prostate cancer as well. Only that for the prostate cancer, you don't just screen routinely. You have to sit with the patient. You explain to them the cons and pros of the screening.
Yes.
So now you can decide whether to screen or not to screen.
Oh, okay.
Yeah.
So like every organ can get cancer?
Yes, apart from maybe hair and
and teeth.
and teeth.
Oh.
But there are organs that are at a higher risk of getting cancer. Okay. And there are some organs like the heart.
Yes.
It is not common. It's very rare to get somebody with heart cancer.
Yes.
Because the mutations that we talked about, the genetic mutations, occurs during replication or during the time that the cells are dividing.
Yes.
So the cells or the parts of the body that are dividing fast are the ones that are more likely to get the mutations and hence more likely to get the cancer.
Yes.
So like in Kenya, the 5 top in Kenya, there's breast, there's cervix, there's prostate, there's esophagus or what we call throat cancer, and then there's colorectal. Those are the 5 commonest cancers in Kenya.
Oh, okay.
Yes.
And who are more likely to get cancers? Are they women or men?
We have more women with cancer, but it's based on the fact that breast cancer and cervical cancer are more. They are the leading causes of cancers.
Yes.
But if you go to something like esophageal cancer or what we call throat cancer, you find that we have more men with throat cancer
Yes.
than women. But then generally, women, the number of patients we have, women are more.
Okay.
Because of the fact that breast cancer and cervical cancer are the leading causes of cancer.
Yes.
Yes.
In the world, or
In Kenya.
Or in Kenya
In
right
Kenya,
now.
yeah.
In this episode, I think we can talk about throat cancer.
Okay.
Because you've said it is also one of the leading cancers in the country.
Yes.
So, what are the causes of throat cancer?
Okay, throat cancer, or what we call esophageal cancer.
Yeah.
There are two main types.
Okay.
There's what we call, it depends with the types of cells that are affected, or the part of the esophagus.
Yes.
That is affected. The upper part, it's mostly we call it squamous cells. I don't want to use a lot of jargons.
Yeah.
And then, or the cells are a bit different from the ones in the lower esophagus. The ones that are in lower esophagus, they resemble more the stomach.
Yes.
So the lower esophagus, the causes of the two, or the predisposing factors of the two, are a bit different.
Yes.
For the squamous cell, mostly it is smoking and tobacco, and something that is a bit worrying, hot tea. Has also been implicated in causing esophageal cancer. Then in the lower part of esophagus is mostly things like H. pylori, or acidity, or what we call reflux, acid reflux, can predispose to throat cancer.
Okay.
Yes.
What about ice? If hot tea can cause throat cancer, what about very cold things like ice cream?
Okay, the science behind hot beverage, let me say beverage, because it is not the tea itself. It's because as you're drinking, if it is hot, there are macro injuries or macro burns to the skin.
Okay.
And now you get burns today, you get burns tomorrow, you get burns the other day.
Yes.
So that prolonged inflammation from these burns are the ones that will predispose to the cancer.
Yes.
When it comes to cold things, most of the time, by the time they reach the throat, it's already warm. If you put ice in your mouth, it melts almost immediately because the mouth is warm.
Yes.
So far there is no studies that are showing that cold things predispose to esophageal cancer.
So what are the symptoms?
Unfortunately, throat cancer or esophageal cancer are one of those cancers that most of the time, by the time they bring out symptoms, it is too late. Because the biggest symptoms that will come with esophageal cancer, it's inability to swallow.
Yeah.
You're trying to swallow. For the first time, that is usually gradual, or it's progressive. So it starts with you are not able to swallow meat, and then as you progress, you're struggling to swallow ugali. As you progress, you're struggling to swallow porridge. As you progress, you're not able to swallow even water or even saliva. So the biggest factor or the biggest symptoms is that inability to swallow. So because I've said that by the time these symptoms occur, it is a bit late.
Yeah.
So most of the time we do not have symptoms until it is at that now it has started blocking the food passage. And now because of that, it is blocking the food passage, you're not able to feed. Now there is things like anemia start developing, a person start wasting, so you start, the person start losing weight. Things like that. And then now when it gets to advance, it has invaded the structures that are around. Now maybe there's a fistula between the esophagus and the trachea. The trachea is the windpipe. So now you start coughing. So coughing now becomes a symptom at that point.
And when you're talking about difficulty in swallowing, is it because of the pain or swelling?
Mostly, most of the time, cancer is not painful. And by the time it is painful, most of the time the pain will occur at an advanced stage. So it is just because the esophagus is being blocked by the tumor or by the cancer that is protruding, the mass.
And how is that treated?
There are three main ways of treating cancer of the esophagus, but mainly it depends on how big or the location of the cancer. So the first thing is surgery. Surgery is one of the things, but sometimes now when it comes to esophageal cancer, it's a bit tricky for the surgery. So the second form, or the most common, is what we call radiotherapy. What we commonly say in layman, kuchomwa. It's just, it's like X-rays being used to destroy those cancer cells. And that is I can say the gold standard, because not everybody will be a candidate for surgery. So radiotherapy is the main form of treatment. But then sometimes, because radiotherapy, we've said it is X-ray, and as they destroy the cancer cells, they are also, they will also destroy some of the normal cells that are in that surrounding area. So sometimes if the cancer is too big, the doctor is not able to radiate or to trauma all that area, because the bigger the area you radiate, the more the side effect to the adjacent structures. So sometimes we can give chemotherapy, what we call neoadjuvant chemotherapy, meaning that we are giving the chemotherapy to make the radiotherapy, the place that we radiate, a bit smaller, so that now radiotherapy can be possible. And then finally, if now the cancer has spread to other parts of the body, you cannot radiate every part. So at that point now you give chemotherapy, which is now a systemic therapy. The diagnosis is a camera, the endoscopy. A camera is passed through your throat. It finds where the problem is. Then it gets a tissue biopsy. The biopsy is taken to the lab. It then now confirms that it is cancer, and if it is cancer, which type of the cancer it is. Then now when it is confirmed that it is cancer, you're taken for CT scans, or if you're in a place that a PET scan can be done, it's even better. And then now we are able to see the areas that are affected by the cancer, or what we call now staging. That is now what will determine if it is a surgery candidate, if it is a radiotherapy candidate, if it is a chemotherapy candidate, or if it's a candidate that we require either 2 or 3 modalities of treatment. It has stages. But now the unfortunate part about cancers of the esophagus is that by the time it is diagnosed, it is advanced. Most of the time it is stage 3, stage 4 when the symptoms have started. So in our country, the survival rate is not as good. We give a 5-year survival rate is around 20% in Kenya.
Yeah.
Just because of that factor. But if you go to developed world where they have screening modalities for the esophagus, the esophageal cancer, the survival rate are much, much better
Yes.
than we have in our country.
Yes.
Yeah.
So now you're saying that for guys to be saved from these cancers, they have to be screened earlier.
Yes. The tricky part about esophageal cancer, especially in our country, because the screening modality that is well recommended, it's what we call endoscopic ultrasound. I know you know an ultrasound, eh?
Yeah, for the pregnant women.
Yes, something like that. But now it is done endoscopically.
Oh, endoscopy.
Yes, but it is not available in our setup. So in our setup, there is no clear line between screening and diagnosis, because the difference between the two is that screening, you're doing it when there is no symptoms, when there is nothing. But then diagnosis will involve unatolewa kanyama, or what we call a biopsy. Then it's taken for screening. So the kind of screenings that we have in our country is the endoscopies, or what we call OGD, that it is a camera that is taken through your esophagus.
Yeah.
Then we pick, the first thing is to check how the esophagus look, and then to pick a tissue or a cup sample. Then it is taken to the lab to see if there is cancer or there is no cancer. So I think that is the tricky part about screening of esophageal cancer, and probably that is why we've not had a lot about screening of esophageal cancer.
Yes. Because
now the screening modality, which is endoscopic ultrasound, it's quite expensive, and it's not available in our country.
So does throat nowhere in the country?
I'm not sure if the big private hospitals have,
Yeah.
But as far as the government hospitals are concerned, we do not have.
Why are we so limited to get those things in the country?
Yeah, I think it's expensive.
Yes.
And even doing that one test is expensive to one person. Again, it is expensive.
Yes.
Because it will, and again, the personnel even to do it is also a bit expensive, because it will involve not something like screening of something like cervical cancer, where you just need one person comes, check, and you're done. But something like endoscopic ultrasound will involve a specialized person who is able to do that, which again in our country we do not have a lot of people that can be able to do that kind of ultrasound.
Yes.
Yeah.
And
something like endoscopic ultrasound.
Getting throat cancers are men.
Yeah, still women have.
Yes.
It's only that majority of cases are in men, but also we have women with esophageal cancer. And I think it's because of lifestyles, although it's changing as we progress.
Yes.
Because like men tend to drink more, smoking, men tend to smoke more than women. But when it comes to throat cancer, it's common in both.
Yes.
But only that it is more in men than it is in women. Yes, especially if it is not only esophagus but all the cancers. If it is gotten early, the chances of cure are higher. But then some cancers have a higher cure rate than others. For example, maybe breast cancer, the cure rate of breast cancer is quite high.
Yeah.
But again, it will depend with what kind of breast cancer you have.
Yes.
That is why sometimes I know it's good to know the stage of the disease, because when you get a patient, they will want to know the stage in which their disease is. But what makes more sense is knowing, yes, I have the disease is affecting the esophagus, it is affecting the nodes, it is affecting maybe the vertebra or some. It's good to know where the cancer is affecting, because sometimes stage will not tell you, especially as a layman, it will not tell you much.
Yeah.
I will give an example now with the breast cancer. I said there are 4 types of breast cancer.
Yes.
There are those that even if it is stage 3 or 4, it is not as aggressive as some other forms of cancer. So you might come with a very aggressive type and you're told it is stage 2, and another person comes with a milder type and they are told they're in stage 4, but then you wonder how comes that the stage 4 is still alive na huyu mwingine alikufa.
Yes.
So I think the best thing for maybe people to know, or people with breast cancer to not breast cancer but cancer in general to know, is
Yes.
how big is my cancer and which part is it affecting. Because for example, let's say because we are dealing with esophagus, I can have stage 4 esophageal cancer, but maybe mine is affecting maybe the lungs, and maybe in the lung it is affecting just, it is one part, or it has one mass. Then there's another person, it is still stage 4, but it is affecting the lung, it is in the bone, maybe it is in the liver, but all are stage 4. So I think the most important thing, and what would make a lot of sense to a person, is to know which parts is involved, or how many parts of the bodies are involved, and how aggressive is their cancer. Because yes, you can have stage 4 similar to another person, but it's a totally different thing. Yeah.
So it's possible to have, are more people successfully recovering from cancer today?
Okay, for the case that I have explained,
Yes.
It's not having the cancer at different part. It is the same cancer. Yes, you can have 2 cancers at the same time. That is very much possible.
Okay.
But what we see most is cancer cells are able to move from one part to the other as the cancer progresses. They are able, maybe you had breast cancer, but then imehama, it has gone to the liver, it has gone to the lung, and that is
It's still on the breast.
And it's still on the breast.
Okay.
So even if a person had to come with the maybe liver issues,
Yes.
and then maybe a biopsy is taken, and we find that it is from the breast cancer, it will not be treated as liver cancer, because the origin of that is the breast, or it is whichever part. So you treat it as the part of the body that it has originated from. So I don't know if I make sense. So if it is breast cancer, and it has moved to the bone,
yes,
you cannot say then I have bone cancer. It is breast cancer that has metastasized, or that has moved,
it has spread.
Yes,
Yeah.
it has
also
spread.
It spreads.
Yes.
Yes.
So that is what I was saying.
Yes.
You can have stage 4, but it is a stage 4 that has spread maybe to the liver, and it is one mass. And then you can have stage 4 that has gone to the bone, to the liver, to everywhere.
Okay.
Yes.
And how do you test stages?
It's basically imaging. So the best imaging modality that we have to stage is what we call a PET scan. Only that a PET scan, like in the government facilities, it's only available in KU, Teaching and Referral Hospital. So not everybody would be able to get that. But we have CT scans and MRI that also do quite a good job of doing the staging.
Yeah. I'm very sure actually there are so many people who are not aware about hot tea. Because in most places that I go, I've seen people complain, my tea is not hot enough. I just want hot tea. So I'm sure not very many people, because it's the first time I've heard about hot beverages causing cancer of the throat. People need to be aware of that.
Yeah.
Are you creating this awareness?
Yeah, whenever we get a chance, we like talking about it.
Yes.
I personally like talking about cancer a lot.
Yes.
With the biggest interest of people avoid what can cause cancer.
Yes.
And then again, people getting to know their cancer or diagnosing first. So it's avoidance of predisposing factors and screening or early detection.
Yes.
Yes.
What else do you think the people should know about, especially this throat cancer, that they should stop completely?
If there's one thing that I would ban, it's tobacco completely.
Yes.
Because tobacco has a lot of chemicals, and most of these chemicals are carcinogenic.
Yes.
So tobacco is one of the biggest culprit when it comes to throat cancer. And not only throat cancer, in many types of cancer. Because even when we were in school, we used to joke that if you're asked of a predisposing factors and you don't know any other, just write tobacco.
Yeah.
So tobacco, smoking in any form is not good.
Yes.
Yes.
And what is the government currently doing to curb the spread of cancer?
I'm seeing now there's a lot of screening. There's a lot of improvement in screening, even though we are not where we ought to be.
Yes.
But if you compare now and some few years ago, there's a lot of awareness that is being created. And partly, I would say that the rising cases of cancer are not because the cases are rising as such, but because we are able to diagnose more. Again, what the government, a few years ago, we only used to have cancer centers in the government premises. We only used to have Kenyatta and Moi.
Yes.
But now we are seeing more and more centers with these cancer centers. Again, also the diagnosis of cancer.
Yes.
Or what we call histology. Uko kitambo, my grandpa died in 86 or something. I was not even born.
Yes.
And so when now I grew up, I have gone to school. Now I'm curious. I want to know my family history.
Yes.
And so I start investigating what killed my grandpa. The family members do not know. All they know is that he had problems with what he could eat. He was very choosy with what he could eat. But going to the certificate, the death certificate, it is clearly stated it was stomach cancer. So he had stomach cancer, and that time he would only get testing from Nairobi. Fortunately, he was a wealthy man, so he was able to get the testing. But by that time, you could only get a histology from Kenyatta.
Yes.
Now, you can get the histology from almost every other facility. Some even level 4
Yes.
have the histology. Then even things like PET scan. A few years ago, we didn't have, even in Kenya, we didn't have any facility with PET scan.
Yes.
Then after some years, Aga Khan brought, and it was very costly by then, because I remember it was 100 and something thousand.
Yes.
And by that time, most of the insurance cover were not covering, especially the NHIF.
Yes.
But then, as now we proceeded, NHIF now started covering for the PET scan. After some time, the government brought its own PET scan in KUTRH.
Yeah.
Now SHA is able to cover for the PET scan.
Yeah.
So there's a lot of progress when it comes to cancer care in our facility, in our country.
Oh.
Yeah.
Why is it so expensive to treat cancer?
Cancer.
Yes.
Let me start by saying it's expensive to treat cancer.
Yes.
But it's not as expensive as it was
Yes.
a few years ago.
Okay.
But then, as the years goes, there's a lot of research
Yes.
on cancer.
Yes.
And so there's a lot of new and better drugs that have lesser side effects, which also comes with a cost. Like a few years ago, something like breast cancer, we only used to treat with chemotherapy.
Yes.
And now as years are coming and we are getting newer drugs that we call target therapy,
Yes.
which are also very expensive.
Yeah.
And that is why maybe some of the patients that have the cover, like now the SHA, it's getting depleted so fast. There's advantages and disadvantages of the SHA versus the NHIF.
Yeah.
Because during the NHIF, there used to be delays in prioritization of maybe the oncology services and other services. So you used to apply for prioritization, and sometimes you would stay for even 3 days before you get prioritization. So now you can get the service. But now when it comes to SHA, the prioritization is much faster because they have automated. So you prioritize, within a few minutes, you've gotten your prioritization and you proceed to get the service.
Yes.
The disadvantage with the SHA is that the package is a bit smaller, and they have not regulated it like they had the NHIF. By that I mean, during the time for NHIF, a certain cycle, for example, the NHIF had classified this into simple and then the complex. So the simple chemotherapies, I think it was 25,000. They had given a capitation of 25,000. So you used to, if the chemotherapy is more than 25,000, you had to top up.
Yes.
But most of the time, if it is in a government facility, that used to be enough for most of the chemotherapy, just a few that you would top up. But then when it comes to SHA, unfortunately, there's not that capping. And so patients, so even if a chemotherapy, if it is the simple chemo, you would get prioritization of any amount. And then bearing in mind that the package is small, I think now they improved it, I think now it's 500,000.
Okay. So
it gets depleted very fast. Like the other day I had a patient who was taking some drugs. We came, there's some it was prostate cancer. So the first thing with prostate cancer, there's some injections we give, and there are some tablets we give for like 2 weeks. So we sent a pre-authorization, it came back. It was, I think it was 20 something thousand they got. Then after now they went and did the staging, we saw that we needed to add another drug.
Yeah.
So we decided, because this we can give for the 3 months, it was coming to almost 200,000, and you see it was approved and they got. So that is like 250,000 is already done, and that is the first cycle.
The first cycle.
The first cycle.
Yeah.
So if they come now after the 3 months, they get another one, they will have depleted their cover. So
Yes.
by the time they get to the third cycle, they have nothing. Unlike the NHIF, where now you would get, they would give you, if it is the simple chemo, they would give you 25,000. If it is the complex chemo, they would give you 100,000.
Yeah.
So by that time, you are sure that you would get your 6 cycles come what may. But now with the SHA, it's something different. A patient goes to private hospitals, sometimes with exorbitant prices. They exhaust your cover within the first 2-3 cycles. No, you're left hanging.
Yeah.
Yeah, that's the major issue with the SHA.
Is there hope for a poor person who has cancer?
I would say there is. It's not, the hope is there compared to how it was in the past.
Yes.
In that, as long as you have paid for your SHA and you're able to go, I would advise a government hospital.
Yeah.
And as long as you're not getting the special kind of treatment, most of the time you will get, your cover will cover your treatment. So the problem comes, or the cost implications now come, if you need what we are calling now the complex chemo or the targeted therapy,
Yeah.
Which are a bit expensive for the common mwananchi.
What happens to these common mwananchi who cannot afford this kind of these services?
Fortunately, in government hospitals, most of them, they will get, even if it's not total help, or if they'll not get all what they want, at least they will get something. And there's advantage and maybe disadvantage, because initially during the NHIF, if you're going to a government hospital and you needed to get a certain drugs, you know, in government hospitals, sometimes you find that the drugs are not there.
Yeah.
So as long as you're going in a government hospital or you're going in hospital A, there's no way the NHIF could not pre-authorize or could not authorize in 2 different facilities. But now, if you're a poor person and you come to a government hospital and you're not, there's no certain drug, you're able to go and get the drug still using SHA in a private facility. Now the problem comes if now, because of the exorbitant prices in the private facility, your depletion of the cover.
Yes.
Yeah. So it's true, some patients are really suffering, and some goes and sell even their land, their cows.
Yes.
Yeah.
Just to add some more years to their life.
Yes.
Yes. Since you're an oncologist, and you've been an oncologist, I think, for several years, is there any patient who has ever been cured when he or she is in stage 3 or 4?
Okay. Okay, sometimes cure in stage 3, yes.
Or 4? Yeah.
4 have I seen? I've not seen, but we have, like, I have a patient that was diagnosed with breast cancer in 2020, either 2020 or 2019.
Yes.
And is still alive.
And she was in stage 4?
She was in stage 4.
Yes.
So even if it is in stage 4,
yeah,
and it is not cure, we can add years.
And can it be when you're in stage 4, you're treated and it comes down to stage 3 and then to stage 2? When you're in stage 4, it is just stage 4, there is no reverse?
You can, theoretically it can go down.
Yes.
But when a cancer is diagnosed at stage 4, maybe it was a breast cancer and it has moved maybe to the liver. Maybe you're treated, the liver things disappear. Yes, theoretically, it has downgraded to stage 3.
Yeah.
Only that we do not like saying that, because sometimes there might be microscopic something that we are not able to see.
Yeah.
The only instance that we would say that the stage has downgraded is when maybe it was stage 4, it was in the liver, it was somewhere that it can be removed, so that part of the liver was completely removed, and it has gone to the lab, and they have proved to us that the entire lesion was removed. So at that point, we can downstage. We can say for a fact that now it is in stage, it was stage 4, now it is stage 3.
Okay.
But before we do that, because the imaging, you are not able to see very microscopics, you cannot be able to see.
Yes.
Yeah.
That patient that you're talking about, what could she have, what kind of lifestyle did she change, or what did she do so that she was able to stay for stage 4 for that long?
It's good you brought about maybe the changes that she had to do.
Yeah.
In cancer patients, there's no really major changes. So the only thing that we discourage more is maybe alcohol, cigarette. You stop those in complete, and then you eat a balanced diet. Why I've said I like that question is because there's a lot of misconceptions out here that if you're diagnosed and you have cancer, don't eat this, don't eat this, eat this, eat this, which is misleading.
Yeah.
Especially during the treatment period, because I've seen some of the things that I've seen people saying, usikule nyama, usikunywe maziwa, don't take sugar. During treatment, the treatment for cancer is meant to destroy the cancer cells. But in the process of destroying the cancer cells, sometimes it destroys the normal cells. And for us to repair the cells that are being destroyed, we will need the proteins, we will need the meat, we will need the milk. Some of the cancer treatment will deprive calcium. So we will need the milk for the calcium. So that's something, maybe a misconception that I would like to undo, that you avoid, you don't eat meat, you don't eat proteins, you don't eat whatever. So if you have cancer, the best thing you can do to yourself is to eat a healthy, balanced diet. Basically eat whole grain carbohydrates, eat a substantial amount of proteins, eat vegetables.
Yes.
Yeah.
Somebody said that the toughest in her journey with cancer, the toughest part was treatment. Why is it so?
The same reason I have said.
Yeah.
That especially in the conventional chemotherapy and radiotherapy, how the cancer cells are unique from the normal cells is that they multiply very fast. And so most of the treatment, the chemotherapy and the radiotherapy, target the rapidly dividing cells. So if you get the chemotherapy, or if you get the radiotherapy, the cells that will be destroyed are the cells that are in their cycle. We call the cell cycle.
Yeah.
Those are that are actively dividing at that time. So sometimes you will find that some of the normal cells, especially the lining of we call the gastrointestinal system, the hair is dividing, sometimes the skin is dividing. So because of that, now as they destroy the cancer cells, they will destroy the normal cells. And because of now destroying the normal cells, that is where now the side effect will come.
Yes.
So if it is in the mouth, you get the mouth sores, you get sores around the gastrointestinal tract. If it is the hair, it falls. If it is the skin, it starts darkening, the nails start darkening, you're fatigued. If it is in the bone marrow, there's depression of the bone marrow and that kind of thing. And that is why a balanced diet, especially during treatment, is very important.
There are people who also get cancers and they also have other diseases.
Yeah.
Maybe somebody is diabetic, maybe somebody is HIV positive, maybe somebody is asthmatic or any other disease. Hypertension, yes. Is it more aggressive on people who have other diseases, or is it just normal?
I wouldn't say it is aggressive.
Yes.
But because the fact that we call them comorbidity, the fact that you're dealing with something else, you have two diseases, even the body, it's more hard on the body than a person with one disease.
Yes.
So a comorbidity or having another disease, it will add on, or the cancer will add on to this other disease.
Yes.
So it's important. What I've seen some of the patients do is, because you maybe previously you have hypertension, then as years goes you get cancer.
Yeah.
What I've seen some patients do is forgetting about the hypertension and concentrating on cancer.
Yeah.
I think cancer diagnosis it's huge. So patients forget about these other diseases and concentrate on this, which is not right.
Yes.
Something like hypertension can kill you even faster if it is not well controlled. It can kill you even faster than the cancer. So it is good if you have hypertension and then you get cancer, you have diabetes and then you get cancer. It is important you continue following them together. So you go to your hypertension clinic as you come to the oncology clinic.
Okay.
Yeah.
Are there medications that people are taking that causes cancer? Because there are people who have these diseases that they have been prescribed medication for maybe lifetime, or not necessarily even lifetime, maybe a long period of time. Could they cause cancers?
I would say, not everything that has been studied. So just because it's not documented or it's not known does not mean that it cannot. So, but the only one of the things or one of the medications that have been known to increase the chances of cancer is hormone replacement therapy, which mostly is given to menopausal women. During menopause, there are those symptoms that comes with the menopause.
Yes.
And so what we call hormone replacement therapy. Yes. Now, the hormone replacement therapy has been known to cause breast cancer. So that kind of thing is known to cause. But other diseases, there are some drugs that have been known to be preventive. Example, something like aspirin. People who have taken aspirin for a long time have been known to be preventive against something like colorectal cancer. So there are some drugs that can be a causative or a predisposing factors, but at the same time there are some drugs that could be preventive.
So aspirin can prevent cancer?
Yes.
Okay.
But so, that's not to mean that people take
maybe once a month.
No. That's not to mean that you take the aspirin. Taking it in a month, it would not be significant. Because the people who are studied, there's some people who are put on long-term aspirin because of other factors like maybe stroke or anything to do with clotting.
Yes.
So those patients have been seen to have a reduced risk of getting something like colorectal cancer.
Yes. So many people go to the hospital and they are told maybe you have malaria, maybe you have typhoid, maybe you have these kawaida sicknesses, amoeba. But the moment you tell somebody that they have cancer, their life changes. There are people who are saying that some people have lost their lives because of the news. They have been the news has been broken to them that they have cancer, and then they don't live for long because of stress.
Yeah.
Yes. So is it a myth or is it true that
it is true?
The news can kill.
It's very much true.
Yes.
That is why in cancer or in oncology, it should go hand in hand with something we call palliative care.
Yeah.
Because there's a misconception of this palliative care is just for the people who are dying.
Yes.
But it is much more. Palliative care is about well-being, of the psychological well-being, social well-being. So the moment a patient is diagnosed with cancer, palliative care should start there and then, even if it is stage 1. Not it goes with the oncology care. The oncology care, it will be there to maybe to cure or to reduce the illness, and then palliative care, it will be there to support the well-being of the patient. The counseling, it is important. Not every doctor is able to deliver the news.
Yes.
So in a good oncology care service, where what we do is we have experts in counseling the patient and the relative. So once a diagnosis has been made, they are taken through the counseling sessions as they continue with the oncology. Yeah. Because news of cancer, it's not easy. It's not easy.
Yes.
Yeah. So it's important to get the whole range. Yes. Of the care.
Okay.
Yeah.
Are the medication available?
Mostly, I would say yes. Only that in government hospitals, sometimes they are the stockouts.
Yes.
But majority of the basic drugs,
yes,
are very much available in the country. Only that you'll not find it in any other chemist. But in most of the oncology center or hospitals offering oncology, you will find them there. Only that some of the newer drugs, the targeted therapy, there are some that are not as easy to find because of their expense.
Yes.
Yeah, but most of the basic drugs, they are readily available.
Yes.
Yeah.
Wow. You should come another time.
I will be glad to.
You should come another time. I want us now to get to maybe another cancer, and maybe we can have people who also can ask their questions, because I know people have a lot of questions.
Yeah.
I know we have not covered even that throat cancer 100%.
Yes.
I know there are so many people who have a lot of questions about cancer. People are concerned.
Yes. Yeah.
So guys, you've had it is curable if it is gotten early. And in case you have any question, she will come again.
Yes, definitely I will.
She will come again. So on the comment section, you can just put your questions, and then maybe we can plan. Maybe next week or any other time that you're available.
Yes, I'm available.
Very happy to host you, and our studios are very open.
Yes, I'm happy to be here.
That you can come. We talk to people, because I'm very passionate about creating awareness that they may learn through this platform that we have. Yes.
It's quite important.
Yes.
Yeah, and cancer is, a few years ago, it used to be the third leading cause of death in Kenya, but now it is second. So you never know in a few years time, it will be fast. So it is quite important for people to know about cancer.
Wow, thank you for coming. And guys, make sure you subscribe, make sure you share these episodes, and God will bless you. So thank you for watching.